Hello, everyone, and welcome to today's keynote presentation titled COVID-19 Point of Care Diagnostics, the Importance of Timing and RNA Levels. This webinar is part of the 2021 Microbiology Virtual Week, and I'm Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots. So let's get started. Before we begin, I want to remind everyone that this event is interactive and we encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. Now, if you have any trouble seeing or hearing this presentation, just click on that Ask a Question box located on the far left of your screen. As a reminder, this presentation is educational and offers free continuing education credits. Use that education credits tab located at the top right-hand corner of your presentation window and follow the process to obtain those credits. I now present today's speaker, Dr. Daniel Griffin. He is the Chief of the Division of Infectious Disease at ProHealth New York, an Optum company, and a Senior Fellow for Infectious Disease with UHG Research and Development, and finally the Clinical Instructor of Medicine at Columbia University. For a complete biography of our speaker, please visit the Biography tab at the top right-hand corner of your screen. Dr. Griffin, welcome. You may now begin your presentation, sir.
All right. Well, thank you for that kind introduction. Yeah, definitely people take advantage as we go along and think about what questions you might have. This is sort of your opportunity to hopefully ask me lots of hard questions, try to stump me. But yeah, just to give people a little bit of background, we're going to be talking a lot about the COVID-19 care diagnostics. What are the different tests to determine whether or not someone has or had COVID-19? And let me jump right from my slide here into what are the objectives? What am I hoping at the end of this? We'll say about 45 minutes of me talking and about 15 minutes of people hopefully asking those hard questions. What are people going to walk away with? So one, and I think this is really key, with COVID-19, timing matters. So I'm going to be spending a lot of time going through the viral kinetics and what impact that has on which tests are appropriate when, which tests will be positive when, which tests will be negative when. I want to go through what are all those different tests, what are available testing options. And then I think this is really critical. When you get a result, whether it's positive, whether it's negative, what's the predictive value? What's the likelihood that that result that you just got is accurate, is telling you what you want that to tell you? And I'll just give people a little bit maybe more background. Those are my titles, but we've really done a lot in the testing space. And I feel like I'm working for a company, which yes, sometimes I am. Not only am I a clinician, so not only am I applying these different tests at the point of care when I see a patient in the office, when I see a patient in the hospital, when I see a patient after that, when I'm advising and consulting for our urgent care or primary care physicians. But we also have a large program, and I'm the sort of clinician expert for, where we do screening programs for a lot of movie and television productions. So we've run programs for Lionsgate, Netflix, Amazon Prime, a lot of other businesses that really needed to get back to work, that were losing a lot of money, trying to figure out how can you test. The NHL bubble, I was actually involved in that. So I'm going to talk about a lot of different scenarios. How do we get schools open? How do we get businesses open? And then what do we do when we've got a patient sitting in front of us? Now, this abstract is very wordy, and I think you can go somewhere and read through all of this, but let me just break it down into bullet points. What are we going to be talking about today? So one of the first things I'm going to try to reinforce as we go forward is that critical in control of this pandemic is the ability to rapidly identify infectious individuals prior to their ability to infect others, right? It's no use, and it was no use during the early days of the pandemic when we would call someone 4 days after they got the test to tell them that the test is positive once they probably had already been out and about and infecting others. So I'm going to talk about how critical timing and resulting delays is. And I'm going to be talking a bit about this distinction between an infectious individual and someone that still tests positive. This ties directly into the second point that we're going to spend a lot of time on. Many of the diagnostic tests are expensive and periodically, particularly when we get surges, can suffer from significant resulting delays. And then this is going to tie in as well, and we're going to talk a lot about this concept of cycle threshold, CT values, levels of RNA, and the concept, the important concept, that with low levels of RNA, which are going to correlate with low levels of the antigens, of the proteins that are being picked up, we're going to end up with negative antigen tests. So patients with low levels of RNA and negative antigen tests, as we're going to look through the kinetics here, they appear to be at very low risk for spread of disease. So I'm going to talk about why it's actually not only okay, but may be appropriate to not pick those people up right away and still have a second test looking at that. So, all right. I like to say with COVID, timing matters. Timing is really critical. And so I'm not going to have a lot of slides today, but what I am going to do is I'm going to focus on several slides that really have the graphics that go through the stages of the disease. And we're going to talk about the different levels of the virus. We're going to talk about different levels of the antigens, the timing of infectiousness. So there are several things that we now really, I think, have good evidence to talk about as far as the early stages and testing. So one is that exposure point. And we're going to move on to a graphic here shortly where we look at what is the time from when a person is exposed to when they go ahead and actually start testing positive, start being contagious, start having symptoms. And don't worry, I'm going to talk about, does the Delta variant change that? I think we just happily call it the Delta because that is, for change. Then I'm going to talk about when you go from exposure to the detectable viral replication period. We're going to talk a little bit about where that ties in. When do people first start having symptoms relative to these events? And then, and I think this is really critical, the early inflammatory phase when people end up in the hospital. And I'm going to talk a little bit about maybe there's a different question we're asking during that time. I won't spend quite as much or really much time at all talking about that sort of late secondary infection phase or that late inflammatory or even the multi-system inflammatory phase today. And I will not spend too much time talking on the tail when we start to see the PASC, the post-acute sequelae of COVID, the long COVID, but perhaps in another talk. All right, so this is really the meat of what I'm going to be talking about today. In a sense, this is the money slide. If you could just take one slide and remember it, burn it into your memory, I'm going to say this is the slide because we're going to look at this slide. And I have to say this slide was actually produced initially early on in the pandemic, and it's to a large degree stood the test of time. So I don't give you the key, so I'm going to walk through the key with you together. So what is this T sub E? This is, as I talked about, this is the time of exposure, right? So prior to this is that whole period when hopefully people are rushing out, getting their vaccines, doing all the pre-exposure things they can do to get themselves in good shape, should that exposure actually happen, right? So we let our guard down, we end up in a situation, perhaps it's indoors, perhaps there's no mask on, perhaps the ventilation is not so great, that 10 to 15 minutes or longer cumulative exposure, the person is talking, imagine that, talking, breathing, coughing, sneezing, generating those infectious exposures. And then we realized that happened. Now, I often get this, person that happens. I remember my mom, I got a test the next day. It was negative. I missed the bullet. It's all good. Of course, it's negative the next day because there is a period of time, an incubation period from that time of exposure to the time that a person actually starts having symptoms. So technically, right, in our common usage, the incubation period is the time from exposure to the time that we have disease, right, to the time someone has symptoms. But I think with the amount of testing, there's also sort of a secondary phenomenon, this incubation period, when they might actually, during that incubation period, develop a time to detectable viral replication. And that's where we're going to be going and talking about today. And I'm gonna, on the next slide, don't worry, we're gonna throw in the Delta variant. But let's start off, what did we learn over the last year? Well, we learned that incubation period from time of exposure to when a person might start having symptoms, so T sub S, the time of symptom onset, that window, that incubation period is 2 to 14 days. And what I want everyone to focus on here or I should say this purple line, and then this PCR detection limit, and this infectious level. So what happens over time? And we talk a little bit about our screening approaches. There is a very slow period of time. I mean, the virus is replicating if a person is going to end up symptomatic or infected. But the viral replication is at such a low level, it is below any of our current levels of detection. Then at a certain point, that viral replication really takes off, really exponentially. And I can imagine this as like a slide in the playground, right? The steep steps that you go up, and then you're going to go down a more slow slope on the other side. But there is a period of time when that viral replication increases to a point where we can actually start to detect it with our PCR tests. Right? So this is the traditional, that beautiful test where a Q-tip initially was plunged deep into the darkness, a blind maneuver. It was rotated, it was pulled back out and sent off for our PCR testing. We still do a lot of that. We can talk a little bit about, does it really need to be that deep nasopharyngeal middle turbinate swab, or can it be anterior nares? But there is a window here when the PCR will pick it up before a person becomes infectious. This has been critical to all our screening programs for a lot of, say, the movie entertainment industry. What we've been doing, and I'm going to go through some calculators, some online tools, but what we've been doing at great expense to the management of these studios is having everyone at the end of the workday, so in a sense, before the next workday, the evening before the next workday, getting everyone PCR tested. If they come back positive, we're picking them up before they go to the workplace and become infectious. This infectious level, as I'm going to talk a little bit, this is when you start having so much virus that the antigen becomes detectable by these rapid tests. So what we've successfully done now for over a year is catch people ahead of time when they still have a PCR detectable level, but have not reached an infectious level. If we get a positive test the next morning, we might confirm this, or if the story is good, we're good to go. But this is this critical window, but I want to say this window is small, and we're going to talk about how Delta has impacted the size of that window. This initially, the ancestral variants that we were seeing, so Wuhan, Beta, Gamma, this was actually many, many hours, maybe a day to go from this period here, where we can first detect viral replication to the part where we get infectious. We then have a period of time, right? Here's our little window. And now for about 2 days, right? So you're going to add that upfront PCR, but now we have about 2 days when a person on average is infectious before they start having symptoms. And this has been critical in a lot of our testing and screening programs. This is not influenza. This is not SARS-1. This is a virus where a chunk of the transmission occurs either in the pre-symptomatic or in some cases the asymptomatic individual. So you can see from this period of time, from the vertical dashed red line out to the solid red line, we have a period of pre-symptomatic where a person is going to test positive both by our rapid antigen tests that correlate very well with infectious levels. They're also going to test positive with PCR. They are going to continue to test positive by both modalities for the next 3 to 4 to 5 days. Then what is going to happen is the level of the viral RNA, which correlates with antigen, so really the antigen level is going to drop. The virus is going to drop below an infectious level. It's also going to drop below a level where our antigen tests are going to continue to be positive. So I want to really point out, this is really this level here. The PCR test is going to continue out. We have descriptions of people 100 days out still testing positive. But certainly people continue to test PCR positive 10 days, 20 days, where that antigen positivity, that level of infectiousness is really a much more narrow window. All right. Before I move to Delta, I just want to point out when we see people in the hospital, right? So we have people who we're either seeing and sending to the hospital, or we're seeing, they are usually no longer in this early viral replication period. They're no longer in the sort of the viral symptom phase. These are individuals that are starting to have that early inflammatory phase. Some of us early on called this the cytokine storm. Other people called it the pulmonary phase. We've kind of, I guess, agreed to agree on the early inflammatory phase, which captures a lot of this. This is when the level of the virus is starting to drop. That may actually be to the point where we're no longer picking it up with the antigen tests. This is where the PCR, I'm going to sort of say, is the right test to go with. Think about timing when we're picking different tests. So, all right, now, this is great, but Dr. Griffin, what about the Delta variant? Does that change things? Are there different tests? Are there different kinetics? And I'm going to go ahead and say it seems like there is. The Delta variant seems to be spreading twice as fast as the other variants, right? It has quickly competed. I mean, I say now, when you get a COVID test in the United States, when you get a SARS-CoV-2 test in the United States, it's a Delta test at this point. We'll see if any other variants can outcompete Delta. And how has it done it? How is it twice as fast? Well, we don't know all of the science here, but one thing we do know is that incubation period seems to be impacted. Before, on average, the median time from exposure to a positive test was 7 to 8 days. It now appears that that is about 4 days, so about twice as quick. We also suspect that this upslope is shorter. It looks like that first test, when you get it back, you have much higher levels. So there's a steeper slope. There is a shift to the left. So let's shift and see what that now looks like. This does actually change things. So does the Delta variant change things? I'm going to suggest that the data we have suggests that we need to slightly redo our flow chart, our diagram, our thinking. What we're seeing now is that time from exposure out to about 4 days. And when the person is testing positive at 4 days, that upslope is very quick now. We're actually, I think, making that window between a positive PCR and a positive antigen test now just a matter of hours, right? We still haven't seen failures yet in our screening programs. And a lot of programs have now added sort of same early morning antigen tests so that you don't, miss someone from the day before. I say a test is great, but a test does not predict the future. But this is a big shift that we're seeing with the Delta variant. That PCR quick detection is not maybe as important as it used to be. That PCR that's 72 hours in the past is becoming less reliable because that person can very quickly go to a point where they have more than an infectious level of virus. Now, we don't know about the other side. We don't know if this changes the slope on the other side. If a person is vaccinated, right? We have nice kinetics out of Singapore and a few other studies showing that the period of infectiousness looks like it is truncated with vaccine. So we may have a rapid rise in viral RNA. It may not even all be effective virus, because about 50% of those people are not making enough nucleocapsid or viral proteins to be picked up with our antigen tests. So two things change this. The Delta variant changes the kinetics here, but vaccines also change the kinetics here on the tail end here. All right, so let's go to what are our different tests. Let's apply this knowledge now that we have it. There's really two main types of tests that we're using. We're using direct virus detection. You're sort of asking that question in your patient, or your patient wants to know the answer to the question, do I have it now? And the second is going to be an area that I'm not going to talk quite as much about, but it really is, did I have it before, right? So serology tests. I think actually, in all honesty, people are asking, am I going to get it in the future? A lot of times when they're requesting that serology test, they're asking the question of, is there some protection I have? Is it waning? And we won't go there today, but I'm sure other speakers will talk about that. But let's really focus on this direct virus testing, either picking up viral nucleic acid through a nucleic acid amplification test, or antigen testing. And most of those antigen tests are going after nucleocapsid, which, at least for the B cells, is the immunodominant protein. It's the most produced protein. T cells, a little smarter, they seem to be targeting the spike right from the get-go. So let's look at our tests. Let's look at, I'm going to say, sensitivity. So just clicked on that. I'm going to go to the next one here. All right, so I want to get a little sophistication here. A lot of times people just ask, how sensitive is this test? The tests are actually very, very sensitive. All the tests are very, very sensitive if we're asking about picking up someone who has infectious levels of virus. But there's a different sensitivity if we're just trying to pick up someone who has a small amount. And so hopefully people are kind of getting this as we get to this part. So we're doing our screening programs. We want to pick someone up who's just starting to have amplification of the virus in that early phase, right? So we want to pick them up before they go to the production studio or the job, or before they get in front of that class and teach the unvaccinated children. A very, very sensitive test for picking up low levels of RNA is going to be our PCR testing, right? We're running these out to 40 or more cycles, right? The more RNA there, the quicker you amplify that up, right? So, if you have millions or billions of RNA copies, you only have to run so many cycles, 10, 20 cycles, and the machine, goes off, dings, we have a result. If there's a tiny amount there, we're going to have to run it, 39, 40 cycles. And when we do that, we can pick up someone who only has about 1,000 or less hundreds of RNA copies, right? So incredibly sensitive. That's great picking them up front, but also think about our curve. That's also going to be great when they show up in the hospital. They're starting to decompensate. They're starting to require oxygen. They're having trouble breathing. Doctor, I've been sick for like 12, 13 days. I think this is COVID, right? At that point, they're probably not infectious anymore. They're past that 10 days. So this is where you're going to want that sensitivity. But what about the person who shows up in the clinic? I'm having trouble, I don't feel well, I got a fever, I've got a headache, and you want to know, is that person not only acutely infected, but are they contagious? I mean, do we want someone going into the workplace? So as you can see, as you go through here, as you get to higher RNA copy numbers, as you get towards the peak there at about 1,000, right? About 1,000 RNA copy number. That's going to be about 36 cycles that you're going to be running that PCR. when you get to an RNA copy number of about 4,000, that's going to be where the Abbott ID now is going to pick up an individual. And I'm going to sort of pause here to talk about, where are you going to want to get that sample? The middle turbinate, that's going to come up a couple cycles, 2 to 3 cycles earlier than that anterior nares, right? So, if you're really looking for the height of sensitivity, you might think about that. Again, hospitalized patient, really long into the course. I don't want to miss them. I want to know whether or not this is COVID. Okay, you're doing that middle turbinate. But in general, you're testing people on a regular basis. The difference between just a couple cycles on the PCR, you're still gonna get a positive test unless you're talking about someone with just a few hundred RNA copies. Then we get to the next level. This is the level where our rapid antigen tests start to turn positive, and this is actually going to be at a lower level than even the level at which a person is infectious. So we can look here at sort of this quick cheat sheet. You can make a screenshot of this. This is actually from one of our papers where we were talking about testing strategies for schools and businesses. At about an RNA copy number of only 50,000, the rapid antigen tests are going to start to turn positive. People look like they're not really infectious until they're less than 30, until they're in the 20s, really when they have RNA copy numbers in the millions. So people can start be thinking about when you say a test is sensitive or not, if a person has millions of RNA copy number, if they're in that 2 days before, that 3 days after, and I'm going to show you in a couple slides here, in that period when the transmission is occurring, I'm going to say that the rapid antigen tests are no less sensitive than the PCR. It's in the high 90s. Their correlation with transmission and contact tracing and with viral culture data is excellent. PCR is going to continue to stay positive for a long time. You're going to pick up people who had an episode in the past. You're going to pick up people who are not infectious. We want to know that in certain settings. In other settings, you've got to ask, what is the question? Because the sensitivity is relative to the amount of RNA. It's relative to timing. If you go ahead and look at all your PCRs, if you look at that person who's still testing positive 20 days out, you include a bunch of people who are still PCR positive after day 10 with low levels of RNA, the antigen will not pick those people up. And the more of those people in the sample will skew your concept of sensitivity. So I want people to think about that. All right, what do these tests look like? And I don't know if people have actually, in our audience, have actually gone to the lab, but it's kind of neat to go in and see behind the scenes what exactly is going on. Early in the pandemic, here at ProHealth New York, we got a couple of these hologic Panther, and they're actually, we say PCR, but they're a template-mediated amplification. They use a luminosity. They're actually slightly more sensitive than PCR. No one knows what TMA stands for, so we make sure in our verbiage we just say, PCR or equivalent. But these are massive machines. A run will do over 1,000 samples. You want to be a little careful about cross-contamination. The TMA, hologic Panther, PCR equivalent, is going to have a cycle runtime of about 90 minutes, right? So you can, pretty big throughput in these going through the whole process. PCR machines, various forms of those. But then we also have our isothermal amplification. People may be familiar with the Abbott ID now. I've got pictured down here. Really very simple machine, sits there on the counter. We have these scattered throughout most of our 100+ urgent cares in the tri-state area. Person comes in, they get the swab. There's all sort of cassette process here. The Q-tip goes in, and actually this gives you some sort of, it runs for about 12 to 15 minutes. Boy, if it comes up after 5 or 6 minutes, you know that there was a high amount of RNA that was amplified. But then we've also got our antigen tests. We have BD Veritor, we have Quidel, we have this Binax now home test. And I do want to talk a little bit about these as well. because I always get questions like, Dr. Griffin, I want first-class testing. I want to sit up in the front of the airplane. I don't want to be sitting back here and coach with the antigen tests. I want a test that's going to be as sensitive as I can get. Well, hopefully I'm starting to get across like your sensitivity has a lot to do with what question are you asking. Really nice recent study where they were using the COVID cards, the Buy Next Now. They had people doing this at home. Right, so this isn't even a sophisticated clinician with proper training. These are people at home, unsupervised, sticking Q-tips up their nose, 5 circles on either side, putting a couple drops of fluid on this card, putting in the Q-tip and waiting 15 minutes. Incredible sensitivity for picking up people in those 2 days prior to symptoms, 3 days after, high 90s actually. The BD Veritor, a lot like our pregnancy test, right, where a lot of our offices are using these. BD has also come out with one which will not only look for SARS-CoV-2, not only allow you to diagnose COVID, but also have flu on the same strip. So you do that swab and you're getting your influenza, you're getting your COVID test at the same time. And there actually are some quad tests where they're breaking it down into influenza A, influenza B, RSV, and COVID, right? So really nice. And I think the big thing I want to throw here is, right, I talked about how that huge machine, it gets loaded. You wait till you have your 1,000, I think it's 1,080 samples in a run. You wait till you have those all loaded. The runtime may be short, but getting it all loaded, getting it in there, getting the results back out, and then you start having issues with throughput during a surge. This may be the Hologic Panther, the PCR, the template-mediated amplification testing. There may be a resulting delay in there of hours to days, where our rapid tests are going to be giving us results in 15 minutes. I'm going to talk on this next slide about why is a resulting delay such a critical thing for us to be talking about. And this is the COVID-19 transmission dynamics among close contacts of index patients with COVID-19. This is really a great study. It's one of many dots in this line, really demonstrating that the vast majority of transmission occurs in this narrow window of 2 days before and 3 days after symptom onset. So what we have here is actually the adjusted risk, right? So you've been exposed to someone who ends up testing positive for SARS-CoV-2, they have COVID. You want to know what is your risk that you're going to go ahead and get it. And actually, you're only at increased risk if that exposure occurred 2 days before the symptom onset and 3 days after. So I want people to be thinking about the viral kinetics and the PCR testing and the antigen testing. So individual comes in, we're going to take this individual, and they say, I'm not feeling well, I want to get tested. We're going to know ahead of time that this person actually has COVID. We send off that PCR test. They go ahead and 2-3 days later, you get that call that PCR test is positive. You call them. I love this. I use call them. They're at the office. They're at the school. They're at the grocery store. And I say, I'm calling to let you know that PCR test is positive, and I want to know, should I go home right now, or maybe I should finish out the teaching day because we can't get a sub, here at 11 o'clock in the morning. The critical thing here is that if that person who came in during this 2 to 5 day window had been given a rapid test, 15 minutes later, we would have a result. We'd be able to pull them out. Those rapid tests during this 2 days before, 3 days after, high 90s in terms of sensitivity. But what if the person comes and sees you, I haven't been feeling well. I haven't been feeling well for the last 7 days. Now, that person is probably past that period where 90% of the transmission occurs. You might do your antigen test at this point. It comes back negative. Now, this is where you need to be educating the patient. You say, you know what? You may be past that point of infectiousness. We still recommend that there is this isolation for, we'll say, 10 days, right? That's what it is in most states. Some still at 14. I'm going to send off a PCR test because maybe what's going on here is you're below that level. and then you send off the PCR test. And then you've got to make a judgment based on your clinical sensitivity, your pre-test probability that we're about to talk about, and do you tell that individual to isolate while you're waiting for that. But remember, during this 2 days before, 3 days after, that person, if you do a rapid test, you have this opportunity to make the diagnosis within 15 minutes, pull them out, preventing further spread, further exposures. You also have the ability immediately to have them reach out to the people they've exposed. Those people can get in, can get tested. This has become really critical, as I've talked about, with the change in timing with the Delta variant, right? 4 days from exposure to positivity. By the time you might get a delayed PCR result and you track down the exposed individuals, you get them tested, with the Delta variant, they may have already gotten to an infectious level, and you may have a next cycle. You may be chasing your tail. The Delta variant may be getting ahead of you. So this is sort of my plug for go ahead, don't miss an opportunity to do that rapid test. If it's negative, you may want to do a secondary test, but you want to educate the patient. You want to explain to them that that PCR may be more sensitive. It may pick them up, but there might be a resulting delay. And you can even talk to them a little bit about the correlation here between the testing and infectiousness. But again, are on the side of caution. We don't want to let this spread. What about that test? The person comes in, it's a screening program, they have no symptoms, they have no exposure, they don't understand what that means. So let's talk a little bit about understanding the test results. And this is this whole concept about predictive values to this test. And we've bounced in and out here. Early on in the pandemic, everyone was positive. Right? We had 40, 50, 60% test positivity rates here in New York. We really missed this until it was really prevalent in our community. There, a positive test was a positive test. But then in June, early in the summer, we actually got to the point where here in New York, the disease prevalence was actually less than 1%. And we actually were running into the issue, and it doesn't matter what test you're doing, the specificity is pretty similar for whether you're talking about antigen or PCR, but people would test positive, and the majority of times that was a false positive. So I just want to point out here, this is really critical. Your disease prevalence is going to impact whether or not that positive you get is false or really reliable. Once you get above 5%, then yeah, your false positive rate is going to drop down less than 20. Once you get where, unfortunately, a lot of us are now, 10% or more in a lot of regions, you're looking at, again, that positive predictive value being 90 or higher. But this is critical. This is also the concept where often, if we really need to know, we might do orthogonal, right? We might do another test to sort out what's going on. So I want people to think about that. A lot of settings, they'll say, that's great. Now you feel like you know what's going on, but we're still going to treat a positive as a positive. So this is science. This is what we understand. Bureaucracies, departments of health, political decisions may err on the side of caution. All right. Well, you want to decide which test am I going to do. Hopefully, I've given a lot of information here about what test you want to do at the point of care. I've touched a little on what test you might want to do as far as screening programs. But I also want to introduce some resources here that might help you calculate what is the correct test in a larger screening setting. So we've actually gone ahead. We created this as a public service thing. It's free access. We posted it on parasiteswithoutborders.com. Basically, this testing simulator, which allows you to go in. I'm going to click to the link that you will get. And this is really a simulator that allows you to try a bunch of different options. Say, well, should I try antigen tests? Should we do the PCRs? What's the cost benefit? How many people am I gonna pick up? And at what expense to the management? So just a couple scenarios I'm going to run through. This is I want the gold standard. I want to do everyone getting a PCR test. You can choose which test you want. You can choose the timeline of how long you're going to be doing this. You can look at the population that you're going to focus on. How often am I going to do this? Am I going to do this like every other day? You're going to end up with quite a bill. Your cost per person in this scenario is going to be $5,000. per person for this 100 days, and oh my gosh, we're testing 1,000 people, that's going to be $5 million, right? That's a lot. We are going to end up with 37 infections experienced over this period of time. Now, what if you say that, Dr. Griffin, I don't have $5 million. Let's look at other options. I initially wanted to do a PCR test every other day. You telling me in the movie industry, they're doing one every day. Well, what about a different scenario where we say, well, why don't we do an antigen test? Let's do that antigen test every 4 days for 1,000 people for this period of time. You can actually go ahead and look at the number of infections. You can look at the cost per day. So this is really a way for you to go and try a bunch of different things. Am I going to do confirmatory testing? Yes or no? Go back to the other one. Most of the time we do that, right? Because the unnecessary quarantines, not something that people really want to do. If you say no on confirmatory testing, your quarantines are going to go up. So this is a tool that you can go after this and play around with. All right, well, I want to bring people back because, as I said, this is something I want to burn into people's memory. Again, think about the question you're asking. Do I really need to catch people in this window, which now I'm going to suggest is a matter of hours, less than a day? Do I need to try in a screening program, jump in with PCR? This can be a very expensive way to catch this few hours here. If you're looking at people who have more than an infectious level for the period of time, I'm going to say 2 days before, 3 days after onset of symptoms, the antigen tests are going to very rapidly catch those people. But there will be people that have negative antigen tests, well, a little bit here up front, but more so after 5 days, after that infectious window has started to go down. You still want to know in those individuals in certain settings, do they have COVID? Is this shortness of breath? Is this fever? Is this requirement for oxygen due to COVID? Those people, you're going to want that PCR. You're going to want a test that's going to pick up low levels of virus, that's going to, in a sense, tell you what happened a week ago, 5 days ago. But think about the fact that the antigen test is going to be negative in those settings. Talk to those people the same about, even if that rapid test is negative, if your suspicion is high, you're still going to be talking to them about isolation from the infected. You're still going to be starting to have conversations about who may have been exposed. You really want to talk to them about what not to do in the next few days, not to expand that pool of those who are exposed. All right. Well, let me close with some resources. As I mentioned, if you want to know more, you can go to parasiteswithoutborders.com. We actually have a link to that free calculator to help you if you're making questions or trying to weigh in on school screening programs, on business screening programs. This is a free tool. Go ahead, use it, play around with it. Also, what we do is every week we post what we think are important articles. You want to keep up to date. You want to see the articles, not just the press releases, not just the media take, and we try to keep you up to date on that. Also, Microbe TV, we put out a podcast twice a week, actually. One is a deep dive, if you want to spend 2 hours listening to people like Shane Crotty, Anthony Fauci, give you kind of a deep in-depth into what's going on. Or once a week, we put out a shorter, more focused clinical update, any changes that clinicians might want to know about. And then the other, I hope there are certain questions that come my way in the next 15 minutes. But in the future, if you want to reach out to me, if you have questions, you can send them to info@parasiteswithoutborders.com, and then I will give you a link to my personal email. And look forward to questions, and hopefully this has been helpful.
Extremely helpful. Thank you so much, Dr. Griffin, for that wonderful presentation and for important research. And now to our audience, we will now start the live Q&A portion of our webinar. And if you have any questions, please do so now. Just use that Ask a Question box located at the far left of your screen. So let's get started. We already have some great questions coming in from our audience members. Our first question, Dr. Griffin, what data do you have to say with certainty that only CT24 or lower are infectious? And the second part of that, how do you ensure performance when there is so much variability in sample collection, test performance, CT value differences?
Yeah, so these are great. Oh, these are great questions. So there's a couple things I'll talk about, and I'm going to start first on the procurement, because that is an issue. Who's doing the tests, and I think that there was a bias going into this, right? That only we, the skilled clinicians, could get that sample we need. We need that middle turbinate. It needs to be in there. The person needs to be crying, otherwise, you haven't done it. And I think it was really reassuring when we saw the recent data on the home, the Buy Next Now. These are people doing it at home. They're reading this instruction manual. They're swabbing the anterior nares. They're sticking it into the cart, and we're getting 98% sensitivity in that what we think is the infectious period of time. We had a nice study early on. We actually it was run by one of the Optum groups, the Everett Clinic up in Washington, where we asked that question: do you really need to get that sample where you're in the middle turbinate? Can you just do that anterior nares? And across hundreds of samples in a real-world situation with drive-through testing, it's really about 2-cycle difference between that middle turbinate that the medical professional is gathering and that person swabbing their anterior nares. So yeah, are you going to miss a few percent? Yes, but we have reassuring data based upon the different sites. We have reassuring data based upon people doing it. But what about machine variability? I mean, that's great, Dr. Griffin, we have the sample, but these machines, you're comparing one machine to another machine. The thing here is really, again, you're only seeing 1 or 2 cycle variability. So early on, there was a lot of concern. We got to run those machines out to 40 or more cycles because we're going to miss people. Yeah, we are going to miss people, but very few. You're going to miss people, maybe a few right there at the front during that narrow window when there's very little viral RNA to amplify. Maybe you're going to miss a few people at that tail end after they've passed through that period of time when they now only have hundreds of RNA copy numbers. So we're reassured at the procurement stage. We're reassured at the machine stage. Well, what about those numbers? That's a wonderful chart to have published, but is it true? And I think, again, this is the test of time. There are 2 things that really correlate with infectiousness. It's timing and levels of RNA. And so that 2 days prior, now a lot of contact tracers extended to 4, right? We don't want to miss folks. And we also, even though the majority of infections are being transmitted only about 3 to 4 days after, we also extend that out to 10, in some areas longer. That is a time when, if you look at our contact tracing, that's when transmission is occurring. If you look at our viral culture data, that's where you're seeing it as well. Yeah, how reliable is the 24 as a number? Some people use a slightly higher number. I think Anthony Fauci has used 30. But yeah, you're sort of in the realm there. The higher you use that cutoff, right? You increase your sensitivity. The lower you use it, that's going to adjust as well. But I think those are reasonable numbers. But even more important than numbers is the timing. Even if you have a CT value, but you're 10 days out, you're probably picking up a lot of RNA. You're not picking up viable infectious virus at that point.
Thank you so much, Dr. Griffin. Our next question, and I want to thank our audience. These are great questions coming in. I've had several experiences where the rapid test was negative, and then I have to call the patient with the PCR test comes back positive. I have decided to stop doing the rapid test. Does this make sense?
Okay. Yeah, so this comes up a lot, right? And I was on the Brian Lehrer show. That's this NPR New York talk show, and and the person called in, and it reminded me of these conversations that I've had with urgent care docs who say, Dr. Griffin, I'm just, that happened too many times. My partners are upset with me because I listened to you. I did the rapid test, and now that rapid test said they were negative, but they really were positive. And I want everyone to think about those kinetics, right? So the woman calls in and she says, I was exposed on Saturday night. So I went ahead and I spent my hard-earned money and I got a bunch of these at-home Buy Next Now. There was a sale. It was $20 for 2 tests. So I did a test on Sunday morning. I did a test on Monday morning. I did a test on Tuesday morning. They're still negative. And so But then Friday, I started to not feel well. So I went and they sent off a PCR test, and then they called me on Sunday to say the PCR test was positive. So why did I waste all that money? So a couple things there, right? Again, remember timing. Those tests are going to be negative up front. Those rapid tests are going to be negative on the tail end. The correlation with PCR is during that infectious period of time. So what I tell people is go ahead, do those antigen tests, because they're going to allow you to very rapidly pick up that person who's positive, pull them out of circulation. But you may be jumping in, like for instance, this person with her exposure, if she had done antigens every day, there was going to be a certain day when the PCR came up positive and the antigen wouldn't turn positive until the next day. And then the same thing is going to happen on the tail end, right? That antigen test is only going to stay positive for that sort of 7-day window, and then it's going to turn negative in the PCR test. So think about what test. What you don't want to do, what you don't want to have on you is that phone call I talked about, where you call them, they're at the office, they're in front of a group of children, and you're calling them to tell them the PCR test is positive when you could have rapidly made that diagnosis with an antigen test. But yes, if you do antigen tests and PCRs, you will certainly have periods of time, you'll certainly have multiple anecdotes where that antigen test was negative and now you're calling someone about the positive PCR. So educate the patient up front, talk to your partners, make sure everyone understands the time and the place for the different tests.
Absolutely. Thank you so much. And this next question is related as well. Why do a rapid test when a PCR test is a better test?
Yeah, I mean, there is this perception that, that the PCR is the first class. I don't want that antigen test. It's inexpensive, it's rapid, I want the PCR. And the media really, I think, has done a lot to create this perception. I think the perception is evolving. Again, it's the resulting delay. There's no reason not to do the PCR if the antigen test is negative. If the antigen test is positive, I'm not sure you need to do that PCR. You certainly can do it as well. But really, I hope the takeaway message is don't fail to make that rapid diagnosis, because particularly as we start to surge, the PCR resulting delays are going to really allow the Delta variant to spread faster than our testing.
Thank you so much. And again, thank you to our audience. Dr. Griffin, we have time for one more question. Should we be testing asymptomatic vaccinated people?
Yeah, so this is a great question. And a lot of people, the data is sort of being sorted out here. And I think the interesting was the Providence experience that a lot of people talked about, where we now know that vaccinated people can get infected. We do, and this is in the Providence study, but we know from other experiences and studies that vaccinated people can, probably for a narrower window, transmit. So yeah, there certainly are circumstances. Let's say, you have a 85-year-old mother and she's on chemo and you're going to go visit her. You might want to add an antigen test the morning that you go visit them. Add that extra layer. There definitely are situations. Remember, the antigen test sensitivity relates to how much viral antigen, how much nucleocapsid is there. Whether you're symptomatic or asymptomatic doesn't actually matter. What matters is how much of the material is there that you can detect. So an asymptomatic vaccinated person who might be in a setting where a transmission would be a problem, right? There's never miss an opportunity to test. It's worthwhile throwing that extra layer of protection.
Thank you so much, Dr. Griffin. Actually, we have time for one more question that just came in from our chat area. The audience member says, do you see more thrombotic complications in COVID patients with factor V laden or prosthrobin G2O, is that G2021OA? Is that what it is? Factor 2 mutations. I apologize to the audience if I didn't say it correctly. It's right there in our presenter chat.
So no problem. So factor V Leiden, it's usually deficiency, right, that people are talking about, or the factor 2 mutations, and then birth control, right? So you're throwing them all in there. So a couple things that we'll clearly say. I think this is really important. So one of my other hats is I'm the one infectious disease physician on the American Society of Hematology Anticoagulation Guideline Committee for COVID. So what are our recommendations? What are they based on? clearly people who are hospitalized with COVID have a higher risk of complications than the general population. Do we have enough data to hone down on individuals like this? Not really. So we're really extrapolating from other experience. So a person who comes in with, we'll say, a factor V Leiden deficiency, someone who comes in with a with another one of these, we'll say, hematological abnormalities, so a factor II mutation. We're going to be making a decision about the hospitalized setting. Do we put them on full anticoagulation? Probably. If they're in the ICU, then there's going to be a risk balance here. You put them on full dose anticoagulation, you may decrease the risk of clotting, but you're going to increase the risk of bleeding. So we say the preponderance of evidence favors prophylactic in that setting. But what about outpatients? What about a person shows up or they get a diagnosis of COVID? Should they start taking an aspirin if they have these? Should they be on anticoagulation? I will say to date, we don't recommend that. The biggest thing is to continue to stay active. We think there's a lot about the severity of requiring hospitalization, the other medications, the immobility in that setting. So no, excellent questions. Birth control meds, yeah. I mean, I think this really came to light when people started talking about the risk of, with the J&J vaccine in young women, of clotting complications, the vaccine-induced thrombocytopenic thrombosis. And people said, you know what, we're talking about 1 in 100,000, maybe even more rare than that. That's higher than what we see with birth control pills. So yeah, there is potentially an additive issue here. If you have a young woman, well, any woman, up to the point that they're on birth control pills, they end up in the hospital with COVID. Now you're sort of adding multiple factors that can contribute to risk of venous as well as arterial thrombotic complications.
Dr. Griffin, thank you again for your time, for this presentation. Really great and very helpful. Would you like to provide any closing remarks to our audience before we go?
Well, thank you, everyone, for taking the time to attend. I like to say never miss an opportunity to test. Never miss an opportunity to rapidly identify someone who has COVID. And as we've learned over time, COVID is a viral disease. It can present in so many different ways. The only way to really know if someone has COVID or not is with a COVID test, with a SARS-CoV-2 test.
Dr. Griffin, thank you again for your time and for this presentation. And I just want to also thank our audience for joining us today and for their interesting questions and questions we did not have time for today. And those submitted during the on-demand period will be addressed by our speaker via the contact information that you provided at the time of registration. And this webcast can be viewed on demand for up to 2 years until September 9th, 2023. So Labyrinth will alert you via the email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone, and be safe. Bye-bye.